The History of Anesthesia. Have you ever had surgery? Think about how incredible it is that we can open the human body, remove an inflamed appendix, and close it without thinking twice. This could not be possible without the development of anesthesia. Our story today focuses on the origins and development of the field of anesthesiology. The origin of anesthesia dates back to the late 1800s, when an English minister, Joseph Priestley, that's really his name, started experimenting with the gases that emerged after pouring nitric acid over brass. This formed what he called nitrous air, known today as nitric oxide. Then he mixed this gas with iron filings and mercury to form dephlogisticated nitrous air, or what we now call nitrous oxide. He made a better minister in the end, though. He tried to use the newly discovered gas to cure intestinal diseases. The method? Insufflating the bowels. It wasn't until the 19th century when Humphrey Davy, who abandoned his formal education to study Priestley's work on gases, built an airtight room to breathe nitrous oxide. Previously thought to be deadly, breathing nitrous, he found it produced euphoria as well as analgesia. It appears capable of destroying physical pain, he said, and might be advantageous during surgery. His findings would still go largely unnoticed for nearly 50 years. It did, however, find some entertaining benefits in the meantime, shown here as Davy administers laughing gas as a prescription for scolding wives. But on December 10th, 1844, everything would change. This is the night when med school dropout and showman Gardner Colton was demonstrating the effects of nitrous oxide when his volunteer seriously injured his leg, but get this, showed no signs of pain. Horace Wells, a local dentist that just happened to be in attendance that night, watched in amazement. A light went off in his head. He had Colton administer nitrous oxide the following day for an extraction of one of his own teeth, proving that this new gas would blunt painful responses. Unfortunately, when Wells tried to demonstrate his findings at Massachusetts General Hospital, it flopped. Literally, his patient cried out in pain, unable to hold still. Wells' life spiraled out of control with a chloroform addiction, and eventually he anesthetized himself with his drug and used a straight razor to cut an artery in his leg. He ended his life. The glory of anesthetic gas discovery went instead to Wells' former colleague. On October 16, 1846, William Morton used ether to anesthetize a patient for the removal of a neck mass. The patient stated that he felt no pain. After that, the use of ether for surgical procedures spread rapidly. There is some debate as to who credit really goes to, but it was the painless removal of this neck tumor that led to its popularity. Ether had its downsides, though, like high likelihood of nausea and vomiting, delayed emergence, and flammability. Alternatives emerged, and John Snow, considered to be the first anesthesiologist, popularized chloroform. Also, nitrous oxide reemerged when Gardner Colton, the med school dropout, administered it successfully during thousands of dental procedures. However, at the same time as inhaled anesthetics, local and regional anesthesia was also being developed. The first famous drug, cocaine. Applied topically, cocaine wasn't perfect, though, so as the hollow needle and syringe emerged in 1944 by Francis Rind, several other local anesthetics showed potential for their biologically active alkaloid properties. Among them, morphine, strychnine, atropine, and brucine are all examples. Relatively inactive when taken orally, they demonstrate dramatic results when introduced into a wound. Also, bacteria and sterile technique were simultaneously being discovered, making the injected drugs safe to administer. More on cocaine. It was isolated from the Andean plant Erythroxylum coca in 1856 and injected directly into the nerve trunks in 1884. In 1905, the less toxic cousin procaine was introduced. By 1911, percutaneous nerve blockage of the brachial plexus was performed, and the study and perfection of peripheral nerve blocking continues to this day. Injections directly into the spine were successfully studied by August Beer in 1899. Spinal anesthesia would go through refinement through to the 1920s. Epidurals, like those used in labor and delivery, would then be described by Fidel Pages in 1921. But it was Achille Dogliati who perfected the famous loss of resistance method that is still taught today for properly identifying the epidural space. Neuraxial blocks remain a popular method to provide surgical anesthesia. At this time, around the 1930s, tracheal intubation found favor for securing a patient's airway and delivering positive pressure ventilation to the lungs. Among the anesthesiologists involved in modifying the laryngoscope to fit their needs was Ivan McIntosh. He pointed out many advantages for the use of a tracheal tube. McIntosh blades used on direct laryngoscopy are among the most popular used today. Increased interest in tracheal intubation and controlled ventilation led to the use of paralyzing drugs known as neuromuscular blocking agents, the famous one being curare. 200 years before its medical application, curare was used in arrow poisons for hunting in South America. Its active compound was eventually found in the bark of certain vines that grew in the forests of South America. Claude Bernard is to thank for localizing curare's effects to the neuromuscular junction in 1857. A husband and wife, Richard and Ruth Gill, would eventually leave their hacienda in search of curare for research purposes. They would find 25 pounds of curare paste and deliver it to Squibb & Sons Pharmaceutical Company. This company would eventually seek out several anesthesiologists to begin clinical trials for surgical muscle relaxation. Eventually, Harold Griffith and Enid Johnson would report successful abdominal muscle relaxation in their 1942 landmark paper. Eventually, the inhaled use of chloroform would get an upgrade too, as safer non-flammable inhaled anesthetics were introduced. These include halothane, enflurane, and isoflurane. IV drugs like etomidate and propofol would also be introduced. With propofol, it would become possible to administer anesthesia without an inhaled substance. Opioids were introduced in the 1960s to offer intraoperative pain control and to manage hemodynamic response or change in blood pressure to surgical stimulation. Knowing that no single drug could provide all the desired effects of anesthesia, in 1926, work at the Mayo Clinic by John Lundy would introduce the concept of balanced anesthesia. This involves multiple drugs to attain unconsciousness, pain control, and muscle relaxation. Combining multiple agents could produce the characteristics of an ideal general anesthetic. Increased monitoring evolved, as did the anesthesia machine, a workstation fully equipped with portable gas tanks, ventilators, flow meters, and respirometers. Of significance, the pulse oximeter was introduced in 1974. Today, anesthesia is remarkably safe. However, unexpected complications still occur. Thank you for watching.